Thank you. Good morning, Chairman, Co-Chairman, ladies and gentlemen. Today, I would like to present my research in the title of Comparison of the Outcomes Between Operative Treatment and Constraint-Induced Therapy of Forearm and Wrist Deformities in Cerebral Palsy. Upper extremity deformities can be found as high as 83% of all cerebral palsy children, which the common disabilities are forearm pronation and wrist flexion. Several choices of either non-operative and operative can be provided for the treatment. For non-operative treatment, from systematic review and meta-analysis demonstrated that the best method is constraint-induced therapy or CIMT. Patients will be limited their usage of dominant side and induced to use their affected hand. And for the operative method, pronator terrestrial is an operation of choice to eliminate the power of pronation and adopt supination function. And moreover, the best way to correct for wrist deformity is FCU transfer to ECRB to decrease flexion and increase extension force. A prospective cohort study in the year 2015 compared the outcomes between non-operative and operative treatment demonstrated that the surgical treatment provides more functional improvement. However, there are still some limitations due to variation of deformities and interventions included in the study. Moreover, Botox injection is not the best non-operative method according to the systematic review mentioned before. Then, in this study, we conduct the surgery for a specific group of patients with forearm pronation and wrist flexion contractures, comparing with CIMT in terms of functional outcomes, range of motion, and satisfaction. Our hypothesis is operative treatment would provide better outcomes in all dimensions. For methodology, our populations are cerebral palsy patients from Sangwan School and Rama Tibeti Hospital between year 2016 and 2018. Inclusion criteria are patients aged 5 to 16 years old with independent ambulation, have forearm pronation and wrist flexion deformities. They are able to use their affected hand just for stabilizing weight or active grabbing object but holding it weakly. Exclusion criteria include patients with fixed joint contracture, insensible hand, have history of surgery or medical injections at upper limb within 3 months, or they are unable to obtain the operation or refuse to participate in the study. The study design is a single-blind randomized controlled trial which randomization by computerized flow with closed-end envelope concealment. Sample size was calculated according to the journal published before and add up more 20% for dropout rate. Therefore, we need at least 16 patients for the study, 8 for each group. Patients will be allocated into 2 groups of treatment. For the operation, we use pronator terrestrial for correcting forearm pronation and FCU transfer to ECRB for correcting wrist flexion deformity. And another group is CMT, which in our study, we provide 5 weeks program by constrain the dominant hand with gloves 8 hours a day, while practicing the children for the affected hand 2 hours daily with motivational action that proper with their age. We assess 3 main aspects of outcomes, which are functional performance, range of motion, and satisfaction score. All data has been collected by video recorder, questionnaire, and logbook for each patient. Then statistical analysis will be done according to types of data with intention to treat analysis. For the study process, after we assess the eligible criteria, 23 children were recruited, but 4 of them were excluded due to unwilling to participate. 19 patients were randomized to receive either CIMT or operation. Then all the patients were followed up at 3, 6, and 12 months, and all the outcomes were evaluated. There was no patients who lost follow-up during the process. And for the results, demographic data of both groups were not different. The primary outcome is functional performance, which we evaluated by 3 aspects of SHUI. The score was better for operative group in all dimensions. However, there's still no statistically significant change between surgery and CIMT group. The secondary outcomes are for the position and art of motion of forearm and wrist. None of these has significant change in each group or between groups, except for the wrist position representing by change of workman's ankles shows significant improvement in surgery treatment compared to CIMT. Our last assessment is satisfaction score demonstrated by Palsy, including 6 dimensions of the score. Happiness scale and also other scores were improved in operative group except pain, but there was still no statistical significance between CIMT and surgery group. And for the discussion, functional performance and range of motion showed more improvement in both CIMT and operative group, while satisfaction score tend to be better just in the operative group. But all this has no significant difference. However, there was only wrist position represented by workman's ankle was statistically improved in operative treatment compared to CIMT. And I believe that the improvement, I believe that the improvement of the workman ankle after the operation would lead to the better hand position and function, especially when patients need to do the grasping and releasing, and as demonstrating in these videos. And for the conclusion, functional outcomes, range of motion, and satisfaction score were not different between CIMT and operative groups. However, surgical treatment could provide better wrist position representing by workman's ankle. I want to give a special thanks to all of my advisors and research team members. Thank you for your attention.